Thank you for joining us today. My name is Chris Lytle. I'm Deputy Director of Systems for Action and your moderator today. Welcome to our Research in Progress webinar. For folks less familiar with Systems for Action, S4A is a signature research program of the Robert Wood Johnson Foundation, housed at the Colorado School of Public Health. And when our medical, social, and public health systems are misaligned, there are negative consequences for our population health and for advancing health equity. So we support studies, testing mechanisms intended to align and connect these systems, while actively creating opportunities to get these critical findings into the hands of policymakers and health and social service practitioners across the country. Today, we'll hear about an S4A project led by Dr. Beth Resnick, who look to measure state and local government spending on health, public health, and social and community services to improve health and reduce disparities. She'll kick off this discussion by walking through their findings and making a connection to our current pandemic before going into a discussion with David Bashai and JP Leader. Throughout, we ask you all to ask questions. You can enter them in the Q&A box, and we'll make time for questions at the end. Please don't be shy. Thank you all for being here. And without further ado, I would like to introduce Dr. Beth Resnick. She's a senior scientist at the Johns Hopkins Bloomberg School of Public Health, Department of Health Policy and Management, and is an Assistant Dean for Public Health Practice and Training and Director of the MSBH Program in Health Policy. Lots of titles. If you want to learn more, read more about her background and expertise, we'll be including these slides, uploading these slides up to our website, systemsforaction.org. So I'll pass the mic along to Beth and her team, and thanks for joining us.
Great, thank you so much, Chris, and thank you everyone, and thanks for everyone who's on. I hope everyone's doing okay, and for those of you that are directly involved in their response, I just want to thank you. It's definitely stressful times, but also important times for us. And we are actually looking forward to sharing our research and its relevance to what's going on, and look forward to our discussion so we can all contribute to thoughts about how we can take what we've been learning and use it to advance our field and our ability to prepare and respond. So first, we're going to be talking about our specific research findings and then the relevancy in particular in light of COVID-19 responses. Then we want to talk about plans for building on this work. And then lastly, as I said, we're really looking forward to discussion. I know in this format, you guys have to use the chat box, but we encourage you guys to engage with us because this really needs to be a collective effort and think about how to move forward during these important times. So thank you again for this opportunity. And we look forward to talking with you today about this. Somehow I'm not able to move. Oh, here we go. Okay, so we've been talking about this for a long time. Our team's been working on this, and generally people kind of glaze over and not really understand what we're talking about or why does it matter. But right now it does matter a lot. So we're going to explain this and talk about why it's really important. So there's national estimates, and now hopefully many of you have already been seeing this in the national news and requests in terms of how much are we really spending on public health. So what the national efforts, the public health activity estimate indicates, and is this red line here on the top, is that of all the spending, only 3% is actually on public health. So the whole blue box is all the health care, but the little red line on the top is what, and I think you'll probably see a lot of national estimates saying that 3 cents on every dollar of healthcare goes to public health. But what we're actually found is that that is most likely not accurate. So we want to share this. And again, why this is important is when we're really thinking about what we need to support public health. the estimates that we're looking at are, we think, very overinflated. Even this little line should be even thinner. So first of all, let me just tell you a little bit about what we did and what this data set is so everybody can understand. We use the Census State Finance Division data, and we have a data set, the State Health Expenditure data set. So first, let me just tell you the strengths about this. We recoded the census data. The one that's available publicly, which I think we'll show you the link, is from 2000 to 2013. We have continued work on this, so the data we're going to be showing you today is actually updated all the way through 2018. But the one that's publicly available, which we can put the link up, that you can get on the website, is from 2000 to 2013. We looked at the red line that I just showed you before, that public health activity estimate. This is the data, this census data is what is actually used to develop that estimate. And it includes spending by all state agencies. So not just your Department of Public Health, it would include the Department of Environment, Department of Agriculture, which is a unique feature because most of the data sets that we're able to look at just include state health departments. So this is a broader database, which gives us a more accurate picture. And it has a very highly detailed line item expenditure. So we'll show you how we used our coding framework to really help you get a sense of exactly what people are spending. So limitations. There's inconsistencies across states, and again, we'll be showing you some data about this in how they account for their public health spending at the local level, and also how they transfer money from states to locals. There's also some incomplete data. Prior to 2008, we didn't have all states reporting before 2008 electronically, so some of those states were not there. And then a big limitation is that California, the state of California, does not report their data to the US Census of Government. So for those states that we did not have the data for, we had to extrapolate for those states. And the way the data works is the states report to the census, and then the census does the coding. So there can be some errors in terms of what the census categorizes as what we call non-hospital health spending. So that's the non-hospital health spending is what we looked at. It's code 32 for any of you that are familiar with the US Census of Government spending. So we created a framework. We aligned it with the Foundational Public Health Services model to do our coding. So we looked at each line item from all the states that report, and we categorized it into all of these different categories. And you can see on the left, those were what we considered public health services. So you can see traditional environmental health, chronic disease, injury prevention. The other side, the right side, that's the yellow background, is other health services. So again, these were all coded as 32 non-hospital health, but as you can see, many of these services are actually healthcare oriented or individual health services, such as behavioral health or clinical services. So that's what we were trying to parse through all of this data to see what are we actually spending on public health. So another area of why this is so interesting right now, and people are interested in this data, is if we start to look at the COVID-19 response and people are thinking, well, what are we spending the small amount of money we have for public health, what is it actually going towards? You can see if you look in this coding framework, and we are able to pull out numbers by category. So for each box, we could give you a number, total, how much the country spent, and also by state. So you could actually parse it out, for example, if you wanted to say, how much are we spending on emergency response? How much are we spending on communications now, access, linkage, all of these questions that are all of a sudden now super important in the light of the pandemic. And obviously communicable disease, we can look at spending. So again, this gives us a lot of opportunity to really parse through and have a much better understanding, not only of the lack of resources now, but going forward when we think about how we're going to rebuild and transform the public health system, this kind of information is going to be very useful. So with that, I'm going to turn it over to JP to share our results.
Thanks, Beth. So we'll start by highlighting what we see as spending as of 2018 within public health. So as Beth just showed on the last slide, we first kind of take this slice where we look at among non-hospital health spending captured by the census. So not just at health departments, but at every state governmental entity. What activities are they doing that are public health oriented versus other kinds of health or healthcare? So looking here just at what we see in the data for public health services, you can see that about 7% of total across the state government is going to communicable disease, about 31% to MCH. And then you can see in the foundational capabilities on the bottom, we're doing a bit more of a breakout, just so you can kind of get a sense of overall how much each capability is in total. So assessment and all hazards are, of course, critical to COVID and are somewhat modest in terms of total, but not insignificant by any stretch of the imagination. I think one of the important limitations, to repeat what Beth said, is that our coding is only as good as the data that come to us. So if data come to us and we're not able to pull out policy development from other kinds of strategic planning or administration, then that might be an underestimate of the total, right? If there are budget line items that say something is for policy development, then we'll be able to capture it very clearly. Next slide. Actually, let's pop over to the next slide and go right to the pie chart, Beth. So one of the things that we find most striking in these data, and we found this since the very beginning of this project almost 10 years ago, is that such a small percentage of total spending in this non-hospital health bucket goes toward public health. We'll talk about why that matters kind of really concretely for our overall national estimate of public health spending, but what I want to focus on in this slide is you can see that there are these other really critical governmental services: behavioral health, healthcare, environmental protection, disability-related clinical care. These are all really important, but right now they're all kind of just being squished together. And so being able to parse them out can be really helpful, not just for public health, but for the other kinds of services as well. Next slide, please. What that 39% tells us is that the official public health activity estimate that comes out of the Centers for Medicare and Medicaid Services and their national health expenditure accounts is dramatically inflated. So what we present to you here is our estimate of where we think true total public health spending nationally lives, somewhere in the vicinity of 50%, ranging between about 1/3 and 2/3, depending on the year we're talking about. Why is there such a difference? Well, we think that there are two primary reasons. One, the way that the census captures the data is different than how CMS uses the data. Their definitions of what public health are different, and CMS doesn't necessarily account for that in the public health activity estimate. It's a relatively small amount of money compared to all of the other items in the activity estimate. And so it somewhat amounts to a rounding error, but for us in public health, that's a very substantial rounding error. Now, the other challenge is that at the state level, we have really good detailed information on kind of line item spending. But as David will talk about in a second, at the local level, we don't. So the reason we have a range here is we can kind of estimate how much we think at the local level is being spent on public health within this bucket of national non-hospital health spending. So that's why you've got this range in gray here. Next slide. I think that COVID has made clear that there's been a historic underinvestment in public health, and that we need to understand how much is needed in public health, but to get there, we need to know how much is being spent. And so if you think about the last slide where you have the official estimate at now 93.5 billion or a little bit more, but the revised estimate from our group is suggesting maybe half that, right? That's an incredible gulf. And so thinking about what does public health need is really going to depend on which which baseline are you using. Next slide, please. So let me end by just talking about how different states are. What I'm showing here are pie charts for non-hospital health spending by type by state in 2018. The key here is not for you to look at any particular state and see what the split is, but to show how different these states are. This is the number that's being fed from the census to CMS to create the public health activity estimate. But as you can see, state by state, even though this is all going into that one bucket, how much is public health in that state versus the kind of total non-hospital health, including behavioral health or other healthcare, right? It's remarkably different. And so that's why being able to look within a state and not just say what's the total non-hospital health spending, but how much is going to public health or behavioral can be incredibly valuable, especially as we proceed with COVID. So with that, David, will you take over?
Sure, thank you. This is David Bishai speaking. And so what we're now moving is from the level of the state down to the level of the counties. And the counties also do report their, to the Census of Governments, their non-hospital health spending. And what they don't do is report on the line items of this non-hospital health spending. We're not able to break down what this actually goes for. One fair assumption would be that it's the same mix of both public health and behavioral health and environmental and so on, but we just really don't know. What we can see here with the heat map is the dark blue is a $200 per capita spending, which you'll see lighting up in California and New York State and parts of the Northwest. And the lighter blue are the counties with very low levels of per capita non-hospital health spending. I know a lot of you are very familiar with the health maps of the USA. If you can imagine the life expectancy map of the USA, I memorize it. I know you have too. And you'll know that the Mississippi drainage system is one of the shorter life expectancy areas of the country. And so it's striking that the parts of the country, the counties that have the worst life expectancy, light up here as having the lowest per capita non-hospital health spending. You also see dramatic variation even inside a state of high spending and low spending. And one of our research objectives is to see if the state legislature is doing intergovernmental transfers to try to help out their sickest counties and help up those that are weak. Is that why that they're spending? Is it rational, where we would try to help the counties with those lowest life expectancies try to make up for their gap? The preliminary evidence is mounting to be no, states are not playing smart, they're playing politics. So let's go to the next slide. So local findings. We were able to show in recent research that that map idea I showed you actually plays out in statistical analysis, that the more a county spends on non-hospital health, the lower all-cause mortality is. These were models that controlled for total county revenue and what counties spent on hospitals. We were able to do this on data from, we were able to do this on data from 1972 to 2012. We accounted for past history of spending because you don't get the benefits from your public health spending all in 1 year. This is really much like an investment where it pays dividends to your health over time. We were really encouraged to find out that there was a disparity reducing aspect of public health, that the counties with more African Americans were gaining more from the public health spending. So we want to firm up that finding and really try to be much more precise about how much county level health spending can lower racial disparities in mortality. Next slide. So back to what we can see on the transfers, when we do see states move money to local governments and what those were allocated for with our state line items, we're seeing that states are generally putting only 29% of their intergovernmental transfers to public health, and the rest is this basket of other important things, just not public health. So there is intergovernmental transfers. We're suspicious that it is not there to lift up the lagging counties, and we're still trying to make sense of why pie charts look like this instead of something else. Is this being rational? And we think we could do better with what makes a state transfer funds to a local county government for the sake of health. Next slide. So we're wrapping up. Main message of today is that it's worse than you think. Not only is that 3% of every dollar in public health a low number, But that's an overestimate, and we are spending probably half of that on what is really to be considered public health and what is really relevant to the current COVID-19 response. We've seen that pressing needs ahead are to actually show the impact of that actual spending and to make it more rational, to show where there are disparities and where reallocating these funds could get more for American health. We want to do better in the future, and hopefully this future will be a little bit more politically motivated because of the general awareness now of how much public health matters to American health. So let's just wrap up and start getting ready for questions. I can see some showing up in the chat box, and we'll give it back to the moderator to field our questions. Briefly, just to show you what we plan to be doing and what we already have working papers on, are summarizing the state spending data and showing how there are inaccuracies in the official estimates. We are focusing on rural public health performance and trying to inform alignment of US spending priorities. So we are having those working papers in, and we really are glad to be here with the S4A group to think how we could all work together. So let's turn over to the moderator now.
Thank you so much for sharing your work. Definitely fascinating and timely, given our current situation. So we'll take questions now. We'll give everyone a moment to enter those into the Q&A box at the bottom of your screen, and we'll funnel those questions to our presenters. I do want to start with a question not aimed at anyone in particular, so anyone can take this up. But it's interesting to see that there's a direct connection to health outcomes for African Americans based on local expenditure. It really highlights a return of investment when it comes to funding public health. My question is whether that leads you all to a more meta question of whether the way we fund public health makes sense, right? Are there policy levers that we should be looking to pool so that public health public health isn't competing for dollars with other non-hospital health spending?
That's an excellent question. One of the advantages of having long-form data series is you can see how and somewhat why people spend. You don't know exactly, but you can know in relation to major economic or health shocks. And something that I think folks in the field have known anecdotally, and that we certainly see right now, is that public health tends not to be funded prospectively, but reactively. So we see a huge investment after the 2001 kind of bioterrorism attacks, and an incredible growth in infrastructure in the years that followed. And then we see a winnowing, a lack of kind of interest in the federal investment in preparedness. So preparedness is actually one of the only activities in public health that's essentially only federally funded. Everything else has significant state investment, state by state. But when federal funding for preparedness was decreased, that was problematic. And then we had swine flu, right? We were worried about bird flu and then swine flu. And then that was perhaps not as bad as some people thought it should be. And so there was a reduction again. Under general measures of austerity, it's kind of easy to cut public health compared to healthcare, because with healthcare, folks are in front of you. You see that they need resources right now, and with public health, you're saving statistical lives 1, 2, 20 years in the future. So it's somewhat rational for policymakers to respond to their own incentives and try and invest in things where there are identifiable people in need right now. But that has led us to this system where there's an emergency, billions gets poured to public health because we need public health to save us, and it's hard to scale up. And there is crowd out, right? So Glenn has shown that there's crowd out between Medicaid and public health over time. And so it would take really creative thinking to separate out population-based investment from clinical care investment.
Right, and I just want to add on to what JP, or the question where it was saying, are you taking one from the other, like in terms of the pie? And I think that's why we have to be careful how we're labeling things as public health versus not public health, because we don't want to, like as JP and David and I all tried to emphasize, all of this stuff is important. And one of the strengths of this type of analysis is that we have these buckets. So for example, right now, if we hopefully we're going to be able to build on this work. So in the next few years, we can see, okay, was there a huge shift into communicable disease control and the things that we need for COVID-19 response, but yet a massive defunding of everything else in that pie. So it's really about accountability and transparency and making sure that we're not robbing from each other, right? Robbing Peter to pay Paul, or whatever, however that expression is. And that's another strength of this coding, this data set that we can track that, and particularly around vulnerable populations and counties that are the poorest, as David said. So tracking those transfers, who's going to get all the money right now in the response? Is it going to the richer counties? So again, I think this is all really important for accountability.
So this is David Bishai. I just want to take our conversation in a new direction. This is a Systems for Action webinar. And I think staying with the current U.S. healthcare system of, third-party payer-based reimbursement for sickness care is something that really has to come into question from 2020 onward. Just rejiggering this isn't going to work, and to ask for state legislatures to do the bulk of this, and that the money we do spend on public health is largely local, not federal money, something we really didn't emphasize. But there's so much money in the healthcare system for the sickness end that to rejigger a value-based insurance or to do global budgeting on hospitals, or Medicare is already thinking through ways where you could be paid to keep your population healthier. The Systems for Action community really needs to say this system can't work. We cannot go forward with this in the future.
Well, thank you all for those great responses. We are getting quite a few questions, so I want to move along and make sure that we can engage our audiences as well. So I'll start with a question from Deanna. How are you controlling for governance in county / state spending?
Sure. Let me speak to the data side, and then maybe David, you could talk about the modeling side. So Deanna's asking a really great question. In our country, there are all of these different relationships between the state health agency and local health departments. In Florida, it's not the Miami-Dade Department of Health, it's the Florida State Department of Health in Miami-Dade County. They are one and the same, right? It's just a local office. Whereas in Minnesota, where I live, the Minneapolis Department of Health is autonomous from the Minnesota Department of Health. So in these different models, how you count spending does become really challenging. In the data that are from the Association of State and Territorial Health Officials, ASTO, and the National Association of County and City Health Officials, NACCHO, they have pretty detailed top line numbers, I would say, Deanna, on total spending, so we can compare that against what's coming out of the census. And you're right that some states line up better than other states. But because we can account for both state overall spending as well as the local spending, when we look within a state system, we can kind of account for that issue. David?
Yeah, so Deanna, I'm really encouraged by your question, because it's research that we did not really do, and hopefully somebody can, which is to make sense of that county map, because it does look like states where there is much more state control certainly have more uniformity, but perhaps there is some more rationality. And these are questions that we have not yet turned to.
Great. So the next question is from Ellie Albertson. They want to first thank you for your helpful analysis and data, but want to know, based on what you've seen, do you have insight yet on exactly what kinds of public health spending might be most important to reducing mortality or improving health outcomes? So for example, surveillance, health promotion / communication, or any other activities?
The short answer from my side is that the signal is not strong enough yet to pick up that type of question. The best models would really require specific health problems that are being solved by specific health expenditures. And so in our work, when we've been looking at all-cause mortality and all type health spending, that's very coarse. So, you know, for something like infectious disease surveillance, you would require data that shows infectious disease morbidity and mortality. And that's where we break down to try to get meaningful death data from cause of death at a local, certainly at a county, it's impossible. And at a state, you'd be requiring to batch it. So it's not impossible, it's just more challenging, requires a lot of good theory to say, okay, this is the type of spending that would have this effect. One thing we have seen and published already is that vaccination preventable diseases do seem to be related to public health spending. And there is also data in the literature that foodborne illnesses seem to be related, where you can tie a specific type of public health activity to a specific type of health event. You're on much firmer ground and more likely to find something. Over.
Thank you for that response. I just came across a question that really resonated with me, especially considering that our research is focused primarily on action, right? Thinking of ways that we can ensure that our studies aren't just staying in the ivory towers and are actually getting down to folks who can affect change. And then that also broadly including the public. So we had a shy attendee who remained anonymous, who asked where or how should this data be presented so that average Americans outside of public health care can care about this issue. What other questions could you ask or results could you get to get people to demand more public health spending?
Yeah, so that's a good question, and I love this question because it is really important. And this is wonky budget stuff, so, and it's layers and different weeds and complicated. So I do think that's a challenge for us that we need to start thinking about how to communicate this in a way that could resonate with the lay public. I know for the years we've been doing this, we've even had trouble getting people in the public health community to understand what national budget estimates, what does this mean, and how does this translate into what am I doing on a day-to-day basis, or how does this impact the funding for my program, things like that. So but I do think we have a window of opportunity here with COVID-19 in the sense that people are fixated. Again, as JP said, and as that article in the New York Times, we get, you know, reaction and then all of a sudden it declines again. So in this reactive time period, it is really important for us to get our message out, which is, again, why we're interested in building on this work. And I do think we need to do better communications. I mean, clearly we can say now that it's in the public domain, the 3 cents on every dollar is going to public health. Well, no, actually it's more like 1 cent. is a soundbite that could actually be captured. And then, as you said, Chris, this is Systems for Action. So I know that we have already gotten some inquiries from policymakers at the federal level, looking as they're thinking about resource packages for the response. So again, making this information known to them, which is what we're doing, I think is again really important. So, and if other people have some other ideas, or JP or David, you want to comment on that, that'd be great.
I'll say really briefly, this is JP, that one of the biggest challenges I have with these data is that it is so wonky, right? So the idea of that chart that we showed you earlier, that has that one blue line at the top that shows public health spending overall, the official estimate, versus this kind of amorphous gray bar that has significant uncertainty because we just don't have the data to know, right? So the idea that you could go to a policymaker who has asked you, how much money does public health need? And for you to say, there is disagreement about how much is actually spent on public health in the country. That's not a place that we want to be, right? That makes us pretty far behind most of the other folks who are asking for money that can have concrete asks that are based on clear baselines. So I think the baseline is really important. And then I think, as was talked about earlier, really thinking both about what does the system or the infrastructure need in the long term, in addition to whatever the particular need is of the day. So right now, we need lots of investment in potentially contact tracing and other sorts of staff needed for response, but we also need a sustained and substantial investment in public health infrastructure. So kind of parsing that out, right? Parsing those two issues out might be helpful as well.
Great. And, and even understanding that, we may be grossly overestimating how much we're spending. When you're assessing, and this is a question from Jim Cusick, when you're assessing public health investments in rural communities, are you considering the differential impact of per dollar investments? For example, does $1 in an urban setting buy you more, so to speak, than in rural settings?
So this is David Bishai, and that's the type of question we can answer. We did try to do our local county spending analysis of trying to see if county spending affected all-cause mortality. And we did urban-rural and really couldn't pick up much of a signal. Part of that might be a misclassification. What I showed in today's presentation was that we were able to use the proportion African-American versus not. And the more African-Americans were in a county, the stronger the effects of a public health dollar were. We were also able to stratify the counties on their median income, but we're not able to achieve statistical significance on county public health spending being stronger for the poorer counties. So I agree that a public health dollar is going to be of different impact in different places. And like I said before, I think our problem is using all-cause mortality as too coarse and too rough and too weak a signal, and a stronger indicator of population health would help us succeed better.
This is JP. Let me also very briefly say to Jim that when you're thinking about like economies and diseconomies of scale that might exist at a county level, there are significant questions about, is there a basic size the health department has to be able to respond to certain kinds of emergencies or to do certain kinds of activities, right? About, 1,300 or so of our nation's 2,500 health departments are rural. Many, but not all of those are also small. And so that kind of complicates things, right? Because you might have much greater travel time if you're doing a lot of inspections. You might have issues retaining clinical staff if they can go to a local hospital and make significantly more as a nurse in the local hospital. So I don't know if I can directly answer, does $1 buy more in one setting versus another? But I would say it does seem like rural versus urban considerations are somewhat different in terms of what the base infrastructure needs would be.
Thank you for those responses. We have a few other questions, clarifying questions from the audience. Priscilla wants to know if any of you could give examples of things that are included in public health spending. So would a potential vaccine for COVID-19 and testing be included under that category, or primary care that is not hospital-based, but that has been shown to improve population health? Would that be included in public health spending as well?
Well, this is JP. Let me jump in and answer that. So with the data that we have, Priscilla, it's any spending by state governmental entities would be what we're looking at. And so some of the items in your question, if they're done by a private organization, would not be included. So we're really we're not capturing things that go on at the federal level that isn't funding. So if there's something that the FDA is doing, that'll be captured at the federal level, but it would not be captured in the state health expenditure data set. The second part of your question about the primary care, I think that this is a really key point that David and Beth and I have all sort of talked about, but it's worth saying again. You know, when we say we're talking about this as public health spending and something else as behavioral health or disability clinical care or environmental protection or other clinical care, that's not to say that behavioral health care isn't incredibly important for population health. But it is worth saying that they are different things. Sometimes they're even delivered by the same organization, but they're recognized as different activities. And even by CMS that makes the National Health Expenditure accounts, they have their own categories, right? So it's more like what is public health versus some of these other things. It can be a little gray sometimes because they're all really important, but they are different. And so it's worth kind of delineating them to the best of our ability. And that's what we try to do here.
So, and this is Beth, just to be, again, more specific, Priscilla, on your question, like, so if the state coded, say that you mentioned immunization or vaccine for COVID, if they had categorized that, you know, we would look at that line item, and if it said immunization, then we coded it in that coding framework into the immunization bucket. So we looked at every line item. And if it said primary care, like you were saying, we would have put that into other healthcare or direct service. You know, so again, we were going line by line, looking at it and categorizing it into each of those buckets in our coding framework.
That's very helpful. And to stay along the lines of technical questions, Jean or John, apologize if I'm mispronouncing, pointed out that a lot of state, local, intergovernmental transfers are for local services claimed on the back end by state Medicaid, and they want to know if you control for that.
Sure. Yes. So within the census of government, there are all of these different categories, essentially for every activity that you might imagine. And there is a category for third-party reimbursements for medical care, so for medical vendors. And that's where Medicaid tends to be. So at the state level, that is parsed out. It's supposed to be parsed out pretty cleanly from these data. But in our coding, we found actually a lot of dollars going to what we could identify as Medicaid, but the census had not identified as Medicaid. At the local level, you can measure some of these revenue streams, but it's a little coarser, as David said before. It's less an issue at the local level. It's much more an issue for this kind of Medicaid kind of getting into other categories accidentally, basically, as a miscode. That's more an issue at the state level, I would say.
And we have one final question from Joanne, and I'll please let me know if I'm butchering this question. It's a bit lengthy, but in addition to the financing issues, Joanne points out that there seems to be a question of authority to act as well. Pointing out that before the crisis, CDC was looking at issues of aging, dementia, and diabetes, while many local public health authorities were pushing to avoid being drawn into issues of aging persons and trying not to engage in personal health care. And now, during this current pandemic, public authorities are commanding private entities to work in the public interest. Joanne wants to know, how should this tension be resolved, and does your data help inform this?
It's a good question. I think, the question about should public health agencies be involved in direct service has been an ongoing debate since throughout my career. I think, it's been a constant debate, and things are shifting and changing on that question a lot. And I think from our work, not necessarily our data, but that it really is an individual community context decision, right? So what's going on in their own community in terms of what other services are available, and what the access issues are, and the population needs. So I don't know if our data can give you an answer to that based on an individual community, but I do think our data can help communities sort of understand where they are right now and what they're spending. Again, the point that we're making, that what's being categorized as public health spending, is it really on public health services, or is it really more in the clinical care setting? And so that you have a better baseline to then make decisions about what's the best needs for your community. So I don't think our data could tell you specifically what is the right fit for your community or what services your health department should be providing. But I do think it could give insight to communities about where their money's going, and a better understanding of the current baseline before they make those decisions.
Okay. There is actually one other inquiry, and this is for you, Dr. Resnick. They want to know if you are the best contact to discuss data use agreements or research collaborations.
Sure, that would be great. And also the data set that we talked about, the state health, the SHED data set that's on the website, that's actually publicly available, and you can, and I'll share that link here on the chat board, or I guess you guys can share it, that people can access it. But yes, people can for sure contact me.
All right, and if there aren't any further questions, we made it through that a lot quicker than normal. This has been a fascinating conversation, and definitely want to thank Dr. Resnick, David Bishai, and JP Leader in joining us for this discussion and sharing this timely information. We look forward to our audience joining us for our next ResBrock webinars. We'll be back April 29th, same time. And we'll be hearing from Jesus Valero and Heesum Young about integrating cross-sectoral health and social services for the unhoused. And on May 13th, we'll be hearing from Jose Pagan, New York University, and we'll talk about testing an integrated delivery and financing system for older adults with health and social needs. In the meantime, if you're interested in learning more about the research that you just heard and any of the other projects that we have going on across the country, you can find it all on our website, systemsforaction.org. Also follow us on Twitter as well. And by all means, if you or someone you know who is a practitioner or a policymaker who will be interested in learning more about this research and finding ways to apply it to their day-to-day work, feel free to reach out to us. We're always open for discussion and love to hear new possible research questions for us to delve into. So thank you again for sharing this time with us. And we'll look forward to see you in a couple of weeks.
Great. Thanks, everyone.
Thanks.
Right, bye.